With the commercially available products, I think that second line patients who have progressed after 2 lines of therapy for their diffuse large B-cell lymphoma, and I think if you have to ask yourself the question of, could I do a autologous stem cell transplant? Could I give this person Beam and feel that I could get them through that transplant? And if I think I could, or I think I can, then I think that that's a population of patients that are CAR T eligible. Now, there's going to be a whole cohort of patients who have relapsed post a curative intent auto transplant. And in that population, that's where it becomes more difficult. Because I think then you're asking yourself the question, well, could I do an allo transplant in them? Or would I give them, intensive chemotherapy again? And if that answer is yes, that potentially they could get a conditioning regimen for a myeloablative transplant, then I think that that's, once again, a CAR T eligible patient population. Now, diffuse large B-cell lymphoma doesn't care what you're thinking. It's going to grow. And so you have to be on your toes in this setting and have to be planning that if this is a CAR T-cell eligible patient, that you want to be thinking that you're going to do CAR T-cell. And you have to be thinking about, now, what's the pace of their disease? Am I going to need to treat them after I decide to do CAR T-cell therapy and I get approval both from your institution partners, insurance, and the company that you're trying to get the CAR T-cells from to proceed forward with that patient? So again, you're trying to keep the patient healthy enough to get their CAR T-cell therapy, but keeping their disease under control enough that when it is time to get their CAR T-cells have been shipped and processed and then received, that the patient is still in a condition that you can give them back their CAR T-cells. So it's a very tricky situation that we're into. In fact, it's a mindset that I don't know that we've ever had to really be in, and at least I don't remember this in large cell lymphoma. When you're talking to patients and you're saying, now we have to change our mindsets a little bit. What we're looking for is some disease control, right? But I don't want to worsen your performance status. I don't want to hurt your heart. I don't want to hurt your lungs. I definitely don't want to hurt your kidneys, because I need to give some form of lymphodepleting chemotherapy potentially. And you need to have enough reserve for if you have grade 3 cytokine release syndrome, or if you have grade 3 for neurotoxicity, that you have organ reserve, your body can tolerate that degree of toxicity. And I think that those are really the eye-peering questions that we have right now, is can we get to CAR T-cell? And then once we get there, we have to manage the toxicities if they do occur. This is very much on a case-by-case basis. You can have performance statuses which are declining directly related to the lymphoma, right? And so in that situation, you may have to use a little bit more intensive chemotherapy to keep their disease under control while the CAR T-cells are being made. Or you may have a patient who has, a low burden disease, but it's been refractory to everything that has been tried against it. And even though it's progressing slowly, and the patient isn't being affected, it's still one of those lymphomas that's going to shift gears. It's going to go from second gear to fifth gear, and it's going to become life-threatening eventually. You just may have the time to not give them bridging therapy, and you may have the time for their CAR T-cells to be made that you don't have to give them bridging therapy. Now, you're definitely talking to them saying, if you are having any symptoms, we may need to give bridging therapy. But you have to be careful about how close you're giving bridging therapy to lymphodepleting chemotherapy or to CAR T-cell infusion also. So really you're trying to, I call it, is there early bridging or late bridging? And my mindset changes depending upon if I know I'm going to bridge them pre and post apheresis, or if I'm going to try to not bridge them post apheresis.
The choice of patients for CAR T therapy is evolving. Based on the clinical trials, patients had to have relapsed or refractory diffuse large B-cell lymphoma and need to have had at least 2 prior regimens in order to qualify for CAR T therapy. In the NCCN guidelines, we made it clear that patients, for example, who had follicular lymphoma initially and were treated with a regimen containing adriamycin, such as R-CHOP or CHOP, who then developed transformation to diffuse large B-cell lymphoma, could have had only one regimen for the diffuse large B-cell lymphoma and then go to CAR T, whereas the clinical trials required two regimens for the transformation for the large cell lymphoma. I think, as we do in cancer therapy in general, we take treatments that are effective in the relapse setting and then begin to apply them earlier in the course of the disease. And that's being done currently in the ZUMA-7 study from Kite, which is looking at an important question. They're taking patients with high-risk relapsed diffuse large B-cell lymphoma and randomizing them to standard of care, which is salvage chemotherapy or second-line chemotherapy, followed by autologous stem cell transplant, comparing that with CAR T cells right at the time of relapse. It's an important study. I think it's going to be a hard study to accrue, but I think it's an important study. It's being asked also by Novartis and will be asked also by the Juno Celgene group. I think it's an extremely important study. I can see a day where once the toxicities are well worked out and the data are much more clear, that you could perhaps begin to think about CAR T therapy for very high risk diffuse large B-cell lymphoma patients, diffuse large B-cell lymphoma patients as upfront or near upfront treatment, just like we're beginning to do in Hodgkin's lymphoma with checkpoint inhibitors. So I think the history of evolution and improvement in cancer treatment has been to take regimens and treatments that are used at the end and begin to bring them up to the beginning. And I think that's the direction that we may go with CARs.
The selection of patients for CAR T therapy is based on many factors. The first factor would be, do they meet the FDA on-label indication, which is relapsed or refractory diffuse large B-cell lymphoma, transformed follicular lymphoma, or primary mediastinal B-cell lymphoma, and also high-grade lymphoma. So if we take that into consideration, there's still many patients who fit that disease criteria but may not be appropriate for CAR T therapy. It is very important for us to understand the pace of the disease. We do know that we can't really see a patient in consultation and offer the therapy the next day. So if we understand the pace of disease and someone is progressing very rapidly, then we need to know whether we can control the disease for the duration of time, the lag period between seeing the patient and actually being able to offer the therapy. That is the clinical part of it. But there are also other things which are very important. For example, you have to look at patient characteristics as well: age, comorbidities, performance status, and organ function. Are they going to be someone who will be able to withstand the CRS and neurotoxicity which can potentially occur? And finally, it's very important to look at the social support system. If the patient has a caregiver, if they are able to live close to the center which is offering the CAR T therapy. And the last but not the least, there's a financial component to this as well. So that also plays into a role for offering standard of care therapies for these patients.